Good morning, everybody, and welcome to this webinar where we will be focusing on rehabilitation perspectives in relation to post-COVID-19 condition. My name is Anthony Duttine. I am the regional advisor for the Pan American Health Organization on rehabilitation, and it's a great pleasure to welcome you today. Before we begin the program, I just want to explain a couple of the logistics for today's program. We are having English and Spanish simultaneous translation. So you should see on your Zoom menu at the bottom a button that says interpretation that allows you to choose your language of preference, whether that's English or Spanish. We have a mixture of presentations in both English and Spanish today. So please select now if you would rather follow in English or Spanish. We also have international sign interpretation today. That interpretation doesn't require anything from your side to activate. You should see the sign interpreter on the screen at all times during the presentations. We also have captioning in English and Spanish. English can be activated through the Zoom screen. You go to closed captioning or subtítulos in your menu, and you can activate the English captions live that will come across the screen. If you require Spanish subtitles, we are putting a link in the chat for you now, and you can click on that link and it will open a new web browser and you will be able to follow live subtitles in Spanish also. If you're having any difficulties, please let us know in the chat and we can hopefully help you to navigate through the interpretation and the captioning systems. We have a really exciting series of presentations and panels today. We are going to have some questions and answers at the end of each panel, so you can use the Q&A menu in Zoom to ask any questions whilst the panelists are presenting, and hopefully we'll be able to get to some of those questions and answers. So without further ado, because we've got a lot to cover in the next 2 hours, I'm going to hand over to Dr. Anselm Hennis. Dr. Hennis is the Departmental Director of the Non-Communicable Diseases and Mental Health Department at the Pan American Health Organization. Good morning, Dr. Hennis.
Thank you so much, Anthony. Really a pleasure to be here. So esteemed participants and attendees, it is indeed my pleasure and privilege to welcome you to today's webinar on an extremely important topic now facing the world and the Americas, post-COVID-19 condition. The Americas has been the region most heavily impacted by COVID-19. As of this week, there have been more than 142 million confirmed cases and 2.5 million deaths. While the main focus has understandably been in public health measures to prevent the spread of the virus and medical interventions to treat those with life-threatening illnesses, it is clear that recognizing the longer-term health impacts that people continue to experience must also receive our urgent attention. World Health Organization has recognized post-COVID-19 condition, or long COVID, as it is now often called, as a serious issue that we must better understand and address. We know now that COVID-19 can cause a myriad of impairments and activity limitations, including fatigue, cognitive dysfunction or brain fog, cardiac problems, breathing difficulties, and many other symptoms. It is important, however, to recognize that long COVID is a new syndrome, and we're learning more about it all the time. It is therefore critical that we continue to expand research and gather data on this evolving condition. In describing post-COVID-19 condition last year, the importance of early and quality access to rehabilitation was identified as one of the key strategies to support people experiencing this condition. Today, we're launching a web series in post-COVID condition, and we start with the theme of rehabilitation. Rehabilitation interventions such as physical therapy, occupational therapy, and speech and language therapy seeks to optimize functioning for people who experience impairments or activity limitations relating to a health condition. Today, we have gathered several leading experts from the region and beyond to describe rehabilitation perspectives in relation to post-COVID condition. I hope that you all find this webinar valuable and useful, and look forward to your full participation in today's seminar and beyond as we go forward learning more and doing more. Thank you so much and welcome.
Thanks very much, Dr. Hennis. It now gives me great pleasure to hand over to our colleague, Dr. Kritika Kupali, who is the technical lead at the WHO on post-COVID condition, to give an overview of where the WHO thinking currently is in relation to this work. Thank you, Dr. Kupali.
Thank you, and thank you for having me today. So I'm going to give a little bit of an overview of what WHO is doing on post-COVID-19 condition. Okay, so a little bit about what we've been doing since the beginning of the pandemic. So post-COVID-19 condition has been an important part of our work here at WHO, and we've been working on it for the last year and a half. Starting in September of 2020, we started by developing an ICD code for post-COVID condition. And then as time progressed, starting in February of 2021, we launched our webinar series focused on the 3 R's: recognition, research, and rehabilitation. And then simultaneously along with that, we realized it was really important for us to develop a clinical case definition for post-COVID-19 condition. And we started developing that in April of 2021 and worked to do a 2-round Delphi process with experts and patients around the world. And that culminated into us releasing our post-COVID-19 case definition in October of last year. And since this has happened, we have also been continuing to work to improve our understanding of post-COVID condition. We work with our colleagues here at WHO in the Rehab department and the Brain Health department to understand more about the pathophysiology of post-COVID condition, to understand more about the rehab interventions. And we are also working to update our guidelines, and I'll talk about that a little bit more today. So a little bit about post-COVID-19 condition. This is our case definition, and we felt like it was really important for us to have a case definition that had been developed by a consensus process. So, you know, as we discussed earlier, post-COVID condition is something that affects people around the world, and it's important for us to know what we're all talking about and make sure we're on the same page. So from our definition, post-COVID-19 condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that can last for at least 2 months and cannot be explained by an alternative diagnosis. Common symptoms can include fatigue, shortness of breath, cognitive dysfunction, but there are others and generally can impact everyday functioning. It's important to note that symptoms may be new onset following initial recovery from acute COVID-19 episode or persist from initial illness, and that symptoms may also fluctuate or relapse over time. It's also important to note that there may be a separate definition applicable to children, and this is something we're also looking into currently. So a little bit more about the webinars that we have had here at WHO so far. As I said, we started our webinar series back in February of 2021. The first one was focused on recognition of the burden of disease. And during that webinar, it was important for us to have a description of global cohorts with post-COVID-19 condition. We had working groups who described clinical descriptors, laboratory diagnostics, and research priorities for post-COVID condition. And at that point, it became apparent to us that not all patients with COVID-19 had full resolution of symptoms, and some were having emergence of new ones over time. And as you can see, that is reflected in our clinical case definition. After that, we had our second webinar in June of 2021. And this was really focused on trying to understand research priorities and also the potential mechanism of post-COVID-19 condition. And there were a variety of things that were explored. So things from inflammation to immune dysregulation, coagulation, vasculopathy, viral persistence, autonomic dysfunction, endocrine and metabolic abnormalities, along with maladaptation of the ACE2 pathway. And then most recently, in October, we had a webinar focused on rehabilitation needs of patients with post-COVID. And here we introduced rehabilitation to reduce physical, cognitive, and mental health complications, and also had an overview of interventions for rehabilitation and models of care that can be used for patients. So a little bit more about post-COVID-19 condition. Approximately 10 to 20% of people experience persistent or new onset of symptoms after 12 weeks following infection, and it can occur irrespective of initial disease severity. It is an under-recognized condition that is now getting wider recognition, and this again is why it's so important for us to have a universal name for this disease and use post-COVID-19 condition rather than different names so we're all on the same page. Our understanding thus far is mostly from research-rich countries where most of the studies are ongoing, but we're working to expand our understanding regarding the global prevalence of this condition. To that effect, WHO has launched a global clinical platform for COVID-19 that uses anonymized individual level data from hospitalized patients for COVID-19. And now we're building on that, and we've developed our CRF4 to try and learn more about patients who have post-COVID-19 condition. And this is aimed at describing mid and long-term sequelae of patients discharged from hospitals and managed at home. And as you can see there on the bottom of the slide, there's a link to that clinical platform. So a little bit about the global clinical a little bit more about the global clinical platform. Okay, so to date, we have close to 500,000 patients, and we have about 70,000 patients from PAHO. And as I mentioned, we are also trying to get more data on post-COVID-19 condition. And so this is a little schematic of our CRF for post-COVID-19 condition. And it has 3 modules. The first module is for the acute COVID-19 episode. And in this module, we collect information on demographics, comorbidities, medications, and any complications the patient may have had during their acute infection. The follow-up module is the physician encounter. We ask information about reinfection, vaccination status, any changes in functional status the patient may have had since their initial infection, and any new signs and symptoms since their acute episode. And then the third module, which also is done on follow-up, we collect information on clinical examinations and laboratory tests. And this has information about different neurological exams, radiographic exams, any other clinical tests and scales, and any other new diagnoses. And as I said, we're really working hard to collect data for our global clinical platform. So if people are interested, please reach out to us and we can give you more information. So some other things that WHO has done is we have our clinical management guidelines, and in there's a chapter on how to manage patients with post-COVID condition. And we are in the process of working to update this. Right now, our clinical guidelines really talk about having pathways to get patients into primary care and work with relevant specialists in mental health, psychosocial providers and social care services and rehabilitation professionals. And that care should be tailored to the patient's needs. And then some of our other ongoing work. So as I mentioned, we have our clinical case definition on post-COVID-19 condition. This was published in Lancet Infectious Diseases. And if you're interested in learning more about the Delphi process that we undertook, that is nicely explained in this publication. As I mentioned, we have our WHO steering committee. We're looking currently at updating our clinical management chapter on post-COVID-19 condition. We also have our rehab group here that's been working really hard to talk about different interim guidance for rehabilitation needs in patients with post-COVID-19 condition. Other things that have happened, we have a post-COVID-19 steering committee. We recently finalized core outcomes for adults, and that manuscript has been submitted to Lancet Respiratory Medicine. And we're working to develop a core outcome set for children and a case definition for children. So as people will talk about today, and I'm sure many of you have heard about, there's a lot that we don't know about post-COVID-19 condition. And we have some priority research questions. So, first off, the natural history. So how is it similar and dissimilar in children versus adults? Understanding more about the clinical characteristics, risk factors, the association with disease severity, and differences in high-income countries versus low-middle-income countries. Understanding more about the pathophysiology. So is it related to viral persistence, immune dysregulation, thrombosis, or is it a combination? Or nothing at all, something that we haven't thought about yet. And then understanding treatments. So the impact on acute therapy and also new treatments and how that might affect post-COVID condition. And then also the impact of COVID-19 vaccination on signs and symptoms people might have. There's emerging data that shows that vaccine may help mitigate the signs and symptoms of post-COVID-19 condition. And so to that effect, I do want to let you guys know that WHO is hosting a global research and innovation forum next week over 2 days from 1 to 6 p.m. Central European time. And we will be talking about the research priorities, and this will be one of the main topics of discussion. So I invite all of you to attend. And then also we are having a continuation of our webinar series in conjunction with our team here in neurology and mental health, and that will be on Tuesday, March 1st from 1:30 to 3:30 p.m. Central European time. And it's really going to be focused on the neurological and mental health complications seen in patients with post-COVID-19 condition. And I think with that, I want to, again, say thank you for having me today. And this work would not be possible without a large number of people. And also, again, if you guys have any interest in our COVID-19 clinical platform, the email for the general address is there. And then also you can contact me directly. Thank you.
Wonderful. I think we can move on to the next section. Anthony, if you don't object. My name is Dr. David Burke. I'm chair of physical medicine and rehabilitation at Emory and also director of brain injury at the Brain Health Center in Emory University in Atlanta. So I'm extremely pleased to be here. I'm thrilled that the group of you has gathered with such expertise about this evolving problem that we see in the clinics every day. I want to expand on the comments made earlier about rehabilitation because beyond the therapies, we certainly are looking at the neuroinflammation, the fatigue, the psychological and cognitive issues that are involved in post-COVID, the long COVID syndrome. So I think all of that I put into rehab because it is critical to the ultimate recovery of the individuals. But I am not one of the speakers, so I will turn this over to our next speaker, who is Dr. Roberto Carlos Sahagún Olmos, who is the Chief of Cardiopulmonary and Geriatric Rehabilitation at the National Institute of Rehabilitation in Mexico. He had obtained his medical degree from the University of San Luis Potosí and his master's degree in medical science from the University of Mexico. He specializes in rehabilitation medicine and cardiac rehab, and he is honoring us today with his presentation. So without further ado, Dr. Sahagún.
Muchas gracias. Vamos a empezar la presentación. Muy bien. El panorama de la rehabilitación de la condición post-COVID en Latinoamérica, pues es algo un poco complejo, bueno, diría demasiado, debido a que de por sí la complejidad de este padecimiento al involucrar varios órganos y sistemas es extenso el compromiso que puede tener. También la situación en Latinoamérica es de consideración especial debido a que muchas de nuestras economías son aún emergentes. Entonces, no siempre los recursos están disponibles para la atención de estos pacientes y los servicios de rehabilitación. Entonces, tras un reporte de 27 casos el 12 de diciembre de 2019 por la Comisión Municipal de la Salud de Wuhan en la República Popular de China, fue como se hizo pública la existencia del SARS-CoV-2. En las siguientes semanas fue reportada en diversos países fuera de China, reportándose de manera oficial el primer caso confirmado el 25 de febrero de 2020 en América Latina. En la actualidad, todos los países están afectados, siendo el más afectado Brasil, Argentina, Colombia y en cuarto lugar México. No obstante, en realidad nuestros países a pesar de tener diferentes niveles y grados de afectación, todos tenemos el mismo reto de nuestras economías emergentes y una limitación en los recursos y acceso a las medidas de rehabilitación. El objetivo inicial de la rehabilitación es mejorar los síntomas de disnea, reducir la ansiedad, reducir complicaciones, minimizar discapacidad, preservar función y mejorar la calidad de vida. Estos son los síntomas más comunes reportados en la infección de post-COVID, y uno de los síntomas graves descritos en la enfermedad en aguda es la disnea. Entonces, como podemos ver, existe un amplio espectro en las manifestaciones clínicas que pueden no ser observadas en personas con COVID-19, el cual puede ser pues desde una infección asintomática hasta una infección severa que pueda afectar diversos órganos y sistemas, llegando incluso a la muerte. De aquí nosotros podemos deducir que los problemas condicionados por esta infección que afecta a múltiples sistemas, puede tener secuelas de estos múltiples sistemas, por lo que los programas de rehabilitación específicamente en personas con afectación severa, aunque no limitado nada más a ellos, es un reto y necesita una valoración extensa. Estos son los fenotipos principalmente descritos de acuerdo al predominio de la afección de diferentes síntomas en la COVID-19, que es cardiopulmonar, osteometabólico y neuropsiquiátrico. Por lo que todo esto debe de evaluarse en cada paciente de manera sistematizada. La condición post-COVID se define como síntomas persistentes por más de 2 semanas y este no es exclusivo de pacientes que cursaron con COVID grave. De ahí la importancia de que los pacientes sean monitorizados aún teniendo las formas consideradas como leves y su prevalencia puede ser desde 10 a tan alta como 87.4%. Lo que pues deja claro de que es necesario un programa de rehabilitación, ya que un gran número de pacientes pueden llegar a presentar secuelas, no limitadas nada más al aparato respiratorio, sino que también en diferentes ámbitos específicamente de la funcionalidad, por lo que esta debe de ser evaluada y se requieren de estrategias integrales, las cuales incluyan a un programa de rehabilitación con todos sus elementos y profesionales involucrados para la evaluación de estos pacientes y pues detección y atención oportuna. La rehabilitación optimiza los resultados en cuanto a salud general y funcionalidad. De ahí su importancia que esta debe de integrarse a los planes nacionales de la emergencia sanitaria de la COVID-19, que muchas veces en algunos países de Latinoamérica pues vamos a decir, limita entre comillas, hacia el salvamento y el tratamiento en agudo de los pacientes, pero muchas veces no se le ha dado, principalmente por cuestiones de presupuesto y situación emergente, pues, adaptación de los sistemas de salud a los programas de rehabilitación. Entonces, existen diversas guías e incluso, pues, cada uno de los distintos equipos de rehabilitación en América Latina están trabajando en sus propios programas. Entonces, generalmente está recomendado de que haya una evaluación sistemática y seguimiento hospitalario, ambulatorio o en la comunidad. Esto de acuerdo al acceso y a la capacidad de los programas y sistemas de salud o no inclusión en programas personalizados. Aquí lo importante es que esto pues esté orientado hacia la necesidad de cada uno de los pacientes, por lo que es difícil establecer una especie de receta para indicar qué necesitan todos los pacientes. Existe una gran diversidad funcional en los pacientes post-COVID, por lo que necesitan una evaluación altamente individualizada que norme las intervenciones de los pacientes recuperados post-COVID-19. En el Instituto Nacional de Rehabilitación, tomando en cuenta estas guías y también lo reportado por diversos autores adaptados a nuestra situación en Latinoamérica, los pacientes en COVID-19, post-COVID-19, le realizamos una evaluación extensa que incluye tanto la historia clínica, exploración, estudio de composición corporal, ya que estos pacientes se sabe que pueden desarrollar sarcopenia posterior al evento de COVID-19. Análisis bioquímicos buscando factores proinflamatorios para intervenir de manera oportuna en caso de que sea necesario, como por ejemplo con anticoagulación. Estudios de imagen para detectar secuelas pulmonares, electrocardiograma, porque un buen porcentaje de estos pacientes pueden tener alteraciones cardiovasculares. Espirometría para establecer si tienen algún déficit de acuerdo a las pruebas de función respiratoria y una evaluación de la capacidad funcional o prueba de esfuerzo. En esta podemos saber cuál es la capacidad funcional del paciente, hablando en términos de VO2, lo cual está estrechamente relacionado con la calidad de vida y el desempeño físico de los pacientes del día a día, que si recordamos, la disnea es uno de los principales síntomas de los cuales estos pacientes reportan que persiste y la fatiga. Entonces, al identificar estos trastornos funcionales, utilizamos escalas de calidad de vida, ansiedad, depresión, trastornos respiratorios y del sueño, somnolencia, trastornos motores, sensoriales y cognitivos, por lo que se necesita una evaluación extensa y en parte nos apoyamos en instrumentos de evaluación como son la JUDAS-2, Huckel-Brecht, Hamilton, Epworth, para establecer los pacientes cuáles son los déficits y algunas afectaciones funcionales y establecer programas altamente especializados y individualizados. Entonces, el tratamiento médico también incluye, tratamiento rehabilitatorio, la intervención de psicología, nutrición, cardiología, neumología y obviamente terapia física y ocupacional. E iniciamos con programa de fisioterapia respiratoria, el cual pues ayuda a que el paciente desarrolle un adecuado fortalecimiento de los músculos respiratorios y mejore sus patrones y también establezca estrategias de ahorro de energía. También otorgamos una prescripción del ejercicio orientada a mejorar la condición física de estos pacientes para ayudar a mejorar su desempeño funcional, especialmente, pero no limitado al aspecto físico, lo cual al paciente le ayuda de manera enorme a mejorar su calidad de vida. Estos programas usualmente duran de 8 a 6 semanas y en los resultados que nosotros hemos obtenido en nuestro programa de rehabilitación es que hemos observado después de 8 semanas una disminución en la grasa visceral, incremento en la capacidad funcional, perdón.
Mil disculpas, doctor Sahogan. Solamente si tú puedes hablar un poquito más despacio para el intérprete. Mil gracias.
Disculpe. En nuestro programa nosotros observamos que hay una disminución del índice de masa corporal, una disminución en la grasa visceral también, un incremento en la VO2 máxima, que es la capacidad funcional, y una mejoría en los dominios de desempeño físico de Huckel-Brecht y JUDAS 2.0. Entonces, los pacientes pues reportaron mejor calidad de vida y disminución de la percepción de discapacidad. En América Latina tenemos que vencer retos específicos de nuestras áreas, como que escasean los servicios de rehabilitación y aún más si hablamos de servicios de rehabilitación orientados a pacientes post-COVID, con componentes de rehabilitación cardíaca y pulmonar. Muchas veces nuestro equipamiento puede ser escaso y en algunas situaciones nulo, y incluso se ha reportado que hay pobre abastecimiento de equipo de protección personal, lo cual pues es una limitación, especialmente en las etapas de atención aguda del programa, y existe un desconocimiento de las guías de manejo. Las oportunidades que existen es establecer programas médicos de posgrado para la capacitación de los pacientes en estas disciplinas, incrementos en el presupuesto para la salud y mejorar estas condiciones relacionadas con la infraestructura y la creación de programas no nada más ambulatorios, sino también intrahospitalarios. Entonces, ahorita existe una gran demanda debido a la condición emergente, el acceso es limitado, pero el personal está generalmente, de acuerdo a encuestas, interesado en capacitarse en este ámbito y asimismo la población en general incluso está muy interesada y tiene los nuevos puestos en este momento en medicina de rehabilitación y no nada más en Latinoamérica, sino a nivel mundial, lo cual es una oportunidad también para pues destacar la importancia de estos programas y obtener mejores presupuestos. Y algunos recomiendan como manera complementaria la rehabilitación basada en la comunidad como una estrategia complementaria amplia de estos programas. Muchísimas gracias por su atención y discúlpenlo rápido.
Wonderful. Thank you very much, and thank you for the interpretation. That was wonderful. Now we'll move to Dr. Vandersal, who is a board-certified clinical neuropsychologist and associate professor within the Department of Psychiatry and Behavioral Sciences and the Department of Neurology at the Johns Hopkins University School of Medicine. She is a member of the Johns Hopkins Post-Acute COVID-19 team, one of the earliest dedicated multidisciplinary COVID-19 survivorship clinics in the United States, and her work seeks to understand the neuropsychological sequelae and clinical course and treatment needs associated with the COVID-19 infection. So Dr. Vandersol.
Thank you so much for having me. So my goal for this presentation is to help clarify the psychological and cognitive symptoms that are associated with COVID-19 and review what we know about rehabilitative efforts at this point. I won't repeat the WHO case definition, but do want to highlight that neuropsychiatric symptoms are part of the post-acute COVID syndrome. They can reduce patients' quality of life, limit their participation in other rehabilitative interventions, and hinder their return to work efforts. It's been estimated that there will be ultimately over 15 million cases of long COVID. And because the majority of affected individuals are in midlife, there are real concerns about individuals sort of retreating from their normal life roles. And so we need to be able to develop methods to rehabilitate patients and help them return to their family and work responsibilities. There are a number of challenges related to our understanding of the nature, severity, and trajectory of cognitive and mental health symptoms following COVID. There's variability in the symptoms across patients and across time. There's also the possibility of unmasking or exacerbating previously undiagnosed cognitive and psychiatric conditions. We're left to tease apart the effect of the virus from the effect of various treatments. And of course, there's broader pandemic-related distress that's affecting the world more broadly. And so individuals are dealing with their COVID-related psychiatric distress, as well as the pandemic-related issues. But we do have reason to believe that patients experience a worsening of their mental health and cognitive functioning, specifically in relation to their COVID illness. Data from 6-month follow-up of hospitalized patients show that persistent symptoms are very common, both physical and mental health symptoms. In fact, it's the modal outcome. And interestingly, we see fairly similar rates of psychiatric and pulmonary concerns, this being a primarily pulmonary disorder in many ways. And if you stretch that out to 1 year and look even at patients who largely did not require an ICU stay, we're still seeing high rates of physical and mental health symptoms with largely equivalent rates of psychiatric versus some of the more common health symptoms. So how is it affecting our mental health, or the mental health of our patients? We know that when compared to other medical conditions like upper respiratory infections or the flu, and adjusting for appropriate risk factors, having a COVID-19 illness is associated with significantly more first onset psychiatric diagnoses, as well as relapses in existing psychiatric conditions. And we see this even in patients who don't require hospitalization. Anxiety in particular is extremely common post-COVID. From a cognitive perspective, data are emerging that are starting to characterize patient outcomes. One recent review article on objective cognitive performance, so tested rather than subjective patient reports, tell us that patients who are post-infection appear to experience global cognitive declines, particularly with difficulties in memory, attention, more complex cognitive skills such as executive functioning, and verbal fluency. And so this gives us an idea of what types of targets we may have for our cognitive interventions. This is also similar to what we're seeing out of our own data here at Hopkins. I know we'll be speaking about multidisciplinary teams later in this presentation, so I'll just briefly note that our approach at Hopkins has been to apply a post-intensive care unit framework for multidisciplinary care. And we have a very strong component of mental and cognitive health service provision, as well as routine screening for cognitive and mental health symptoms. And at 4 months after illness, our patients who are treated in the ICU, as well as our patients who did not require an ICU stay, they both tend to perform below expectations on most cognitive tests, particularly tests that require speeded thinking efficiency and fluency, processing speed, new learning, and memory. And so this tells us that these are the areas where we're going to really need to intervene to help improve patient cognitive functioning. Additionally, we see high rates of psychiatric distress, as well as functional decline that patients attribute to their cognitive and mood changes. So our PAC structure allows us to detect and intervene so that we can address persistent cognitive and neuropsychiatric symptoms. So we're screening everyone, and depending on the results of that screening in the data that I just showed, patients are routed to appropriate providers. And that may be neuropsychology for cognitive issues or rehab psychology for adjustment to their health change, psychiatry for depression and anxiety treatments. We actually have a fair number of patients who screen positive or endorse thoughts of self-harm. So having a really close tie to psychiatry can be very important because we want to make sure that we're identifying those people and acting quickly to get them the care that they need. Additionally, we often send patients to be seen by our speech language pathologists to help work on various cognitive remediation approaches, and to our social work team to help address other issues that come up from a mental health and more psychosocial perspective. In terms of the scientific literature on post-COVID rehabilitation efforts for cognitive and mental health outcomes, that literature is very tiny. We're really left to rely on interventions in which we have demonstrated efficacy based on what we know from other patient groups. So the WHO recommends, in terms of mental health symptoms, that we provide education and advice on strategies to help establish expectations and tools to help alleviate stress and anxiety. Also provide basic mental health or psychosocial support. And so part of doing that is to routinely screen so that we're able to identify which patients are in need. From a mental health perspective, symptoms of depression, anxiety, and particularly for our patients who required an ICU stay, trauma-related distress or symptoms of PTSD. Those are all things that we need to be looking for routinely, and establishing a network of referrals or care providers so that we can triage patients to the most appropriate level of care for their particular symptom needs. I will note that the International Neuropsychological Association has published a paper with recommendations for the harmonization of both research and clinical batteries, looking at mental health symptoms as well as cognitive symptoms across the globe. And they have a very nice breakdown for higher and lower resourced countries. We're also going to be publishing a survey or conducting a survey here soon, looking more specifically at international needs with respect to the screening tools that we use for our patients. With respect to the cognitive symptoms, cognitive or restorative rehabilitation is recommended, and encouraging patients to continue to engage in their daily activities that they find meaningful. We know from other patient populations, such as concussion or mild TBI, that when patients retreat too far from their daily roles, it can then hinder their recovery. So we want to really help them thread that needle and be as engaged and active as possible while still respecting their ongoing symptoms and the need to change their activities to some degree in response. So what does cognitive rehab look like in post-acute COVID patients? Well, much of it is psychoeducation, helping patients understand their symptoms, set realistic goals, engaging in behavioral activation and making plans for that, using cognitive rehabilitative approaches like memory training, cognitive exercises to help strengthen core cognitive abilities, and training patients in compensatory strategies such as note-taking, using reminders. We focus a lot on goal setting, looking at tracking our symptoms and difficulties, using diaries so that we can understand the antecedents of cognitive and emotional difficulties and figure out ways to help work around those. And then we're also doing a lot of training in basic self-care so that patients are actively addressing the things that they have some control over, such as their sleep, nutrition, physical activity, and socialization. In terms of our general goals, we really want these to be adaptive to the individual needs of a patient and approaches that empower patients to help take control of their health and well-being. But in terms of data, we're still very much lacking on scientific data, specifically as it relates to COVID. What we do see from the preliminary research is that if we look at patients who are recovering on a post-acute inpatient unit, those who participate in individual or group psychotherapy, so once or twice a week getting individual one-on-one therapy or group therapy, that tends to be associated, at least in one study, with improved functional gains by the time of discharge. So targeting mental health symptoms early on in recovery may have broader, more longer term implications for patient outcomes. And then when we think about specifically neuropsychiatric symptoms improvement, we do have data from a small study looking at a 6-week outpatient rehab program that addressed folks many months after their initial diagnosis. And it simply provided psychoeducation on emotional and cognitive changes, sleep, and self-management approaches. And what they found is that patients had improved scores after that 6-week program on a cognitive screener, the MOCA. And there were also improvements in fatigue post-intervention, but no particular benefit for depression and anxiety. This particular study doesn't have a control group. There's really a need here for more research, but also, of course, methodologically sound studies of our interventions. And I expect that those types of data will be forthcoming. And so just to summarize, moving forward, we're going to be looking more at the trajectory of cognitive and mental health symptoms, figuring out the predictors of those persistent issues, and better delineating the care needs of patients and their families so that we can most effectively intervene and provide cognitive rehab interventions at the right time to the right patients. And I will stop there.
Wonderful. Thank you, Dr. Vanderboom. Now to speak of fatigue management and post-COVID condition, lessons from the chronic fatigue community is Professor Todd Davenport, who is a professor and vice chair of the Department of Physical Therapy in the School of Health Sciences at the University of the Pacific in Stockton, California, USA. He's worked on the construction and validation of function-based physical capacity tests for patients with chronic fatiguing illnesses, and has extended his work into the identification of optimal rehabilitation programs for people with chronic post-viral fatigue. So Dr. Davenport, please.
Thank you. I'm trying to start my video so I don't hide behind this probably overly distinguished profile picture that I have, but unfortunately I'm not able to do that right now. Oh, yep, there. I've been requested to start my video. There I am. Thank you so much for the opportunity to speak with you today on applying important lessons from the myalgic encephalomyelitis and chronic fatigue syndrome community and research that's been going on for a number of years. My own involvement with it has extended back to the past 10 to 15 years. I'm looking forward to sharing some insights from the physiology of some very specific symptoms to post-COVID condition, and we'll go ahead and get started. I won't repeat the definition of post-COVID condition, but I will point out, as some of the speakers have already highlighted, that post-COVID condition is a lot of different things rolled over into the same case definition. So really we have post-viral deconditioning and post-intensive care unit syndrome. We have end organ damage, such as from immune response or coagulopathies. We have neuroimmune and autonomic dysregulation, and also the effects of other interventions. And so where I'm going to spend most of my time in this talk is talking about the neuroimmune, autonomic, and metabolic dysregulation that seems to occur in a subset of people with post-COVID condition or long COVID. I just want to point out that the fatigue that we talk about with post-COVID condition is really understating the magnitude of the issue, the burden of the symptom, the impact on daily life. It's more than just tired. So it's really this feeling of nothing left in the tank, being bonked, having to lie down, not being able to engage in any further functional activity. And what's probably unique is in a subset of people with post-COVID condition, this fatigue and constellation of associated symptoms that I'll discuss in a moment are brought on by exercise, brought on by activity. So we call this post-exertional malaise or post-exertional symptom exacerbation. And post-exertional malaise is a whole constellation of different symptoms, including palpitations and tachycardia, orthostatic intolerance, shortness of breath, non-productive cough, even despite normal blood oxygen levels. There's difficulty breathing. There's sensation of weakness. There's chills and sweats and elevated temperature. And so you can get the sense that the fatigue that we're talking about with post-COVID condition, at least in a subset of folks, is more than just fatigue. And in fact, we see phenotypic shifts that occur in the presentation of post-COVID condition over time, in which these memory issues that we just heard about, cognitive dysfunction and brain fog, post-exertional symptoms, and other unusual symptoms along with that very severe fatigue become more frequent in certain patients over time. Here in patients' own words is what post-exertional malaise or what post-exertional symptom exacerbation feels like. It's physically drained, mentally spent. Felt like I was in a barrel and rolled downhill, been through a trauma, hit by a truck, couldn't find enough energy to get going for the day, trouble holding the head and body up, had to recline as much as possible. Terrible headaches as though someone had struck the back of my neck with a baseball bat. So I'm hopeful that you're getting the impression that that folks with post-exertional symptoms, that fatigue really is not covering it. That this is extremely severe and very burdensome to daily life. Clinicians are often tasked with working with their patients to identify causes and effects between different activities, different notable events, and how their symptoms and functional status changes. Post-exertional malaise or post-exertional symptom exacerbation challenges this paradigm because the onset, may vary greatly after precipitating activity. And the duration of post-exertional symptoms may last anywhere from a day to more than a week, more commonly 3 to 7 days. And the rule is that even the duration varies. So it's often very difficult to identify the relationship between a potentially precipitating activity and the symptoms that a patient is experiencing. My colleagues at the Workwell Foundation in Ripon, California, in the United States have been using cardiopulmonary exercise test methodology for the past 15 years to identify cardiac, pulmonary, and metabolic status in people with myalgic encephalomyelitis. And so to give a picture of what we would expect that this methodology should be able to reliably detect small changes in these variables between days. People should be able to reproduce their exercise test measurements. And so other groups have demonstrated this in a variety of different conditions. And so the inability to reproduce a cardiopulmonary exercise test result is the unusual factor here. As it turns out, people living with myalgic encephalomyelitis are unable to reproduce a cardiopulmonary exercise test result at peak exertion and also at ventilatory anaerobic threshold, which is relevant because most of our daily activities occur at or below that VAT value. So again, the difference in sort of physiological performance despite this on this reliable test can be challenged in people with myalgic encephalomyelitis and chronic fatigue syndrome, and particularly on a second test administered 24 hours after the first test. So we see folks perform at a certain level on the first day and perform lower on the second day, particularly at that ventilatory anaerobic threshold measurement, which is reflective of the physiological capacity to do daily activities. So you can imagine the functional implications of that observation. Specifically, our group has found a significant reduction in the volume of oxygen consumed and the workload measurement at ventilatory anaerobic threshold on the second test of a cardiopulmonary exercise test. And in fact, creating a predictive model, including VO2 and workload at that ventilatory anaerobic threshold, correctly classified 95% of patients and 90% of matched sedentary control subjects. So this test methodology can be used to reliably differentiate between people who have post-exertional malaise or post-exertional symptom exacerbation and people who are deconditioned. The inference here, of course, is that this isn't deconditioning. Post-exertional malaise, post-exertional symptom exacerbation is not being down after being ill or having a lower maladaptation to a lower activity level. This is part of the pathophysiology. So in quick summary, patients with post-exertional malaise or post-exertional symptom exacerbation enter anaerobic metabolism earlier during a bout of maximal exercise. This trend is more likely to be present after the day after they have exerted already. And that this really indicates dysfunction of the aerobic energy system that is activity dependent. And so then again, how might this affect housework? Trips to the store, one's life and role with family and in the community. How about trying to work or engaging in other meaningful activities of daily living? With this fluctuating physiology, you can imagine that trying to maintain a predictable functional slate of activities is very difficult. The World Physiotherapy produced a briefing paper in association with long COVID physio involving safe rehabilitation practices for people living with long COVID or post-COVID condition, specifically centered on the role of physical activity and exercise. And as is the social media zeitgeist, if I had to summarize the briefing paper in a hashtag, it would be stop, rest, pace. And this briefing paper has been translated into 11 different languages, including Spanish. Stop, rest, pace really follows a model for analytic management of post-viral fatigue that we've proposed earlier. That first involves pacing, self-management of activities, followed by a very controlled and patient-centered progression of exercise interventions from anaerobic to aerobic, depending on the patient's ability and not on an external guideline or an external benchmark. So really stop, rest, pace is energy system first aid. The intention there is to try and stabilize the pathophysiology that is occurring, to be able to use the energy systems, the short-term energy systems that work, and avoid the longer-term energy systems that do not. In the table, the bolded activities are those that basically occur over the ventilatory anaerobic threshold for on the second day of an exercise test, which means that these bolded activities would be difficult or impossible for people to complete who are in the post-exertional state. Whereas they may be perfectly fine to do it in one session, that next session may be impossible due to the fluctuating physiology and the activity-dependent aerobic system dysfunction that we see in ME/CFS and by association with post-COVID condition. And so really, this raises the importance of educating people who are living with post-COVID condition in energy conservation through pacing, through changing positions to find more metabolically advantageous positions, joint protection, and then also to plan and prioritize activities, seeking help from others when necessary. There are some critical barriers to implement energy system first aid as a frontline intervention to post-COVID condition. The first is public awareness. People just don't know about post-COVID condition or long COVID. I think the media has improved that situation somewhat, but yet you still have folks who are living with this condition that may not be able to identify it and therefore will not be able to refer themselves for help. Also provider training, particularly people who are interested in exercise. We see someone who's tired. We think that we should exercise tired people. And in this case, based on the unique physiology of post-exertional malaise, we know that that actually can be harmful as a frontline intervention. And so provider training for stop, rest, and pace to teach that as a core competency for people who are living with post-COVID condition. Along with that, rehabilitation guidelines that center exercise first are an unfortunately good way of finding people with post-COVID condition who have post-exertional malaise because we exercise professionals will inadvertently push people into a crash that then precipitates finding help for post-exertional malaise or post-exertional symptom exacerbation. Payment policy for rehabilitation services in certain areas is predicated on functional improvement of patients. It's hard to say that patients are functionally improving if you're asking them to do less. So rethinking how rehabilitation services are paid for seems necessary. And then also social policies to support lifestyle modifications that provide for pacing with family supports, school supports, and also work supports seems critical. So in closing, moving beyond energy system first aid is important. There, as I mentioned on the previous slide, there is sort of in the plan to move from anaerobic to aerobic exercise interventions as the patient is able, also considering pharmacologic support for symptoms. And then finally, as we think about these rehabilitation interventions, we can't get too far away from treating the actual disease state, which gets back to the research priorities that Dr. Kapali outlined earlier for these emerging hypotheses regarding the underlying pathology and pathophysiology of post-COVID condition. So thank you so much. I appreciate the chance to share a bit about long COVID, and thank you for your attention.
Wonderful. Thank you for that wonderful presentation. And I think we move to our next moderator.
Dr. Berg, I think we've got some time for some Q&A from this panel. If you want to go straight into that, yeah, that's fine.
All right. We have I've recorded some that you had posted on chat, but does anyone have any task on the screen? Let me start with Dr. Adrian Palmer asked that, prefacing her question with the fact that most countries at the level of the Minister of Health or Department of Health do not have rehabilitation represented. And she asked, what is PAHO and the WHO doing as far as policies in place to ensure that rehabilitation is at the big table, especially at the local level, to assist with this. So
thanks. It's Anthony here. I'm actually going to address that one if we could park that one, because that will come up in my presentation a little bit later on. So it's a fantastic question. Thanks for asking it, but I can talk a little bit more to that in the presentation later. But there are a couple of questions in the Q&A section that I think are specifically directed at the panelists here. If you don't have access to that, I can read a couple of them out if you'd like.
I don't know which ones were, well, it says to everyone, so I didn't have any that I've written or recorded that are specific to a panel member. So if you...
No, please go ahead, Dr. Beck, please go ahead.
Okay, from Nydia Canis, she asks about the undiagnosed active undiagnosed hypoactive delirium in older people that is associated with COVID-19 and post-COVID syndrome. So any of the panelists wish to opine on that? Dr.
Certainly
Van.
from a cognitive and mental health perspective, we know that delirium is associated, particularly in our older adults and our ICU patients, with the deterioration of cognitive functioning, even outside of COVID. So if we're just looking at the critical care literature, delirium is associated with worse cognitive outcomes, and it can sort of kick off what may be a burgeoning cognitive decline in our older adult patients. So it's something that we really do need to be paying close attention to and addressing in the hospital setting aggressively in order to help improve patient outcomes.
If I could follow that up, though, Dr. Van der Zol, since this is your expertise, as you know, depending on the age and preconditions of the elderly who are struck with delirium in the hospital, would post-COVID extend the time of the delirium and therefore make it more difficult to discharge the patient back home and or more likely to need other services outside of the hospital?
That seems to be the case, that it challenges and complicates the medical treatment and may prolong their recovery and their care needs as they transition back to their home environment, certainly.
Okay, well, thank you. And I have a third question from Mario Gomez, again to everyone. And it's a statement, it's somewhat of a question. I think about the traumatic burden generated by health personnel, but I think that's meant to say the trauma that is inflicted upon the health personnel taking care of such a global burden of disease. So would someone like to discuss the burden on the healthcare providers of this post-COVID syndrome and the COVID itself, I suppose? We're certainly daily talking about burnout because of the acute COVID, but I guess if it extends into post-COVID, but I don't know. Does anyone have an opinion on that? Or
I think it's a real issue. You know, our frontline workers, particularly early in the pandemic, were at increased risk of contracting COVID. And so we have a lot within our medical system, a lot of nurses and other medical professionals who have sort of the joint burden of having had COVID and managing persistent symptoms and the stress of returning to a workplace that they view, some of our patients view as dangerous and threatening, and there's sort of a traumatic reaction associated with the concept of going back to a place that, to work in a place where they contracted an illness that really knocked them off their footing. And so our institution, I think many others, are trying to implement strategies and support services for our medical providers who had COVID or who are just dealing with the increased burden. But I do think that changing the zeitgeist, changing the culture and working towards opening our staff and faculty up to self-care and managing their own symptoms and getting the help that they need is something that we're still going to have to push, because I think by the nature of being in a medical system, so many folks are really very hard driving and very dedicated to others, and shifting that focus to take care of oneself is going to require some effort.
Well, having said that, one more follow-up question. Given you're in the northern part of the United States and I'm in the southern, and I assume it's true for many people here that we share the same issues of a shortage of healthcare personnel, and certainly therefore the inability to take time away and to take breaks, mental health breaks. And so I wonder if that is true for other regions where there's just not sufficient personnel to allow for these breaks, and therefore there doesn't seem to be a reasonable way to physically move away from the patients and take care of oneself. So what are the strategies given that scenario? And how does that differ around the different regions that are represented here? Marta, tell me about Brazil.
Well, yes, we as mentioned already, we are also a country that was hit hard with COVID-19. We had the opportunity to assess almost all the patients who survived hospitalization, either from the ICU and from the general wards. And even 3, 6, 12, 15 months after the hospital discharge, they seem to still have difficulties in functioning that required assessment. Fortunately, because of the maybe acuteness of the health condition, the course of treatment, rehabilitation treatment, was somehow short, either as an intensive inpatient care or as an outpatient, compared to what we usually see in rehabilitation settings. And also very important is the task shifting, because, for example, about 70% of the patients who survived, they were rated low, who would require low intensity rehabilitation. So it is, despite the fact it is challenging, it is the variety of the symptoms, but yet when you introduce them into a comprehensive rehabilitation, what we realize is that the time course of that is seems to be short in an integrated, let's say, setting. But of course, then the studies on randomized controlled trials are now coming more and more into the literature, with several protocols already published. So hopefully in the near future, we will have more data to share. Thank you, Professor Burke.
Thank you. Thank you. And so with that report from Sao Paulo, I will move on to the next panel 2 discussion and turn it over to the moderator there. Thank you.
Gracias, Dr. Burke. Muy buenos días. Este panel en realidad va a dar un poquito de cambio hacia aspectos relacionados con la organización y gestión de los servicios para garantizar que esas intervenciones que se hacen a nivel individual, tanto de atención, tratamiento y medidas terapéuticas, puedan ser efectivas para garantizar acceso equitativo a servicios de rehabilitación de calidad. Así que tenemos 3 panelistas con distinguidas panelistas. Yo iré introduciendo a cada una de ellas en la medida que van las presentaciones para no consumir tiempo. En primer lugar tenemos a la doctora Marianela Ríos, que es del Ministerio de Salud de Chile, responsable del área de rehabilitación y discapacidad. La doctora Marianela Ríos nos va a hablar de la definición de estándares para la atención, para la rehabilitación en el contexto de los pacientes post-COVID-19. Doctora Ríos, adelante.
Muy buenos días, muchas gracias por la invitación. Paso a compartir pantalla. Vamos a compartir el establecimiento de estándares para la rehabilitación post-COVID-19 aquí en Chile. Yo soy médico fisiatra y represento en esta oportunidad el Departamento de Rehabilitación y Discapacidad de la Subsecretaría de Salud Pública del Ministerio de Salud de Chile. Sobre todo queremos compartir cómo ha sido nuestra respuesta desde la rehabilitación al COVID-19. Entre muchos factores del COVID-19, incluido la brecha del recurso humano, la reasignación que se requirió de los recursos financieros, las restricciones de acceso a la rehabilitación y la misma contagiosidad y gravedad de los contagios, es que tenemos actualmente un número importante de secuelados en post-COVID-19 en todo el mundo. Aquí vemos el número de contagios al día de ayer acá en Chile y llevamos 2.709.000 casos y de ellos sabemos que más o menos un 10 a 20% debieran quedar con alguna secuela post-COVID. Y de eso hemos visto, según datos de FONASA, el Fondo Nacional de Salud, que es como nuestra seguridad social, que más o menos un 2,5 de estas personas han requerido alguna intervención de rehabilitación. Tanto las secuelas del COVID-19 grave y crítico como del COVID persistente y prolongado generan una mayor carga de enfermedad a nivel global por el aumento de los años vividos con discapacidad. Este deterioro del funcionamiento puede limitar o impedir el retorno a actividades tan importantes como la actividad laboral y que esto puede extenderse incluso por años. Es necesario, por lo tanto, haber contado con una rehabilitación temprana e interdisciplinaria para lograr reducir las complicaciones y las secuelas. Respecto a nuestro enfrentamiento específicamente del post-COVID-19, comentar que se organizó la respuesta de rehabilitación en COVID, asegurando la continuidad de atención desde lo más agudo y sin perder a las personas en el ambulatorio. Y también con énfasis en la pesquisa y el reconocimiento de esta condición persistente y prolongada. Nuestro Departamento de Rehabilitación y Discapacidad dirige y coordina e integra las políticas públicas en rehabilitación, tanto desde el ámbito hospitalario hasta los centros de atención primaria. Y por lo tanto también se estableció coordinaciones intramensal y también con otros organismos gubernamentales para dar una respuesta coordinada, tanto a la etapa aguda como a la post. Inicialmente publicamos una serie de elementos de documentos regulatorios respecto a COVID, del cual aquí destacamos las recomendaciones para la sospecha, el diagnóstico y la rehabilitación de las personas afectadas de COVID-19 persistente y prolongado, el cual fue publicado ya casi hace un año, en marzo del año pasado, reuniendo principalmente la evidencia con la que contábamos hasta ese momento de esta entidad. Como líneas generales del documento y de nuestra respuesta a rehabilitación, situamos como lo más importante la prevención y educación del post-COVID, generando videos educativos a la comunidad y también educación a la población y equipos de salud. Por un lado, recomendaciones. Por otro lado, recomendaciones para el cuidado de las personas post-COVID que podían hacer y con un énfasis en cómo detectar el post-COVID-19. Y un webinar en que hicimos un abordaje clínico rehabilitador para los equipos de salud que contó con una parte especialmente dedicada al post-COVID. Asimismo, dentro de la educación nos hemos enfocado a el reconocimiento de esta enfermedad y evitar la estigmatización de los afectados. Dentro de la detección temprana, elaboramos y está incluido en el documento de recomendaciones este cuestionario de detección de síntomas del COVID-19 prolongado, el cual fue adaptado desde la evidencia disponible y de los cuestionarios que hay a nivel mundial. Nuestro objetivo fue hacer un cuestionario corto que fuese fácil de aplicar en consulta o autoaplicado por las personas, con fin de poder detectar rápidamente a quienes presentaban síntomas prolongados. Este cuestionario ha sido difundido en distintas ocasiones hacia los equipos de salud, principalmente en la atención primaria. Asimismo, hemos coordinado un trabajo intersectorial con participaciones en mesas de trabajo, como la mesa de rehabilitación, salud mental y secuelas por COVID-19 como enfermedad profesional, en la que hemos participado junto con Suceso, que es la Superintendencia de Seguridad Social, organismo que organiza las mutualidades o los lugares que atienden personas con condiciones laborales, junto con el Departamento de Salud Ocupacional de aquí del MinSal y nosotros, y con dos focos principales, que uno ha sido la detección de las personas y por otro lado el evitar que las personas que sean diagnosticadas de un COVID como enfermedad profesional tengan lo que se llama un subsidio cruzado con la asistencia pública, es decir, se sigan atendiendo donde corresponda y viceversa. Para ello hemos hecho distintas submesas enfocadas tanto en la detección como también en el adecuado registro de calidad para poder determinar esto. Y junto con esta mesa hicimos una presentación conjunta a los equipos de atención primaria de todo el país, presentación sobre salud ocupacional, hablamos de aspectos de la ley laboral, de rehabilitación y también del enfrentamiento y detección del long COVID. Estas presentaciones se hizo, como digo, a todos los equipos y también quedan grabadas y disponibles para que lo sigan viendo los mismos equipos. A partir de esta mesa, también un hito importante fue el dictamen de septiembre del año pasado, en que ya se decidió la utilización del código CIE 10 U09.9 para diagnosticar long COVID. Y esto como implicancia de poder detectar nuevamente a quienes lo están padeciendo, llevar un mejor registro. En cuanto al acceso a rehabilitación, lo importante desde el punto de vista del long COVID o post-COVID es establecer el compromiso funcional y a partir de ello hemos visto quienes requieren rehabilitación. Y hemos establecido que quienes tengan un compromiso funcional leve se pueda tratar con pautas y con educación dentro de la difusión que hemos hecho y también proponemos hacer algún seguimiento ya sea presencial o de forma telemática con ellos. Y los que tienen un compromiso funcional moderado y severo debieran ingresar a rehabilitación. El foco del post-COVID lo hemos puesto en la atención primaria de salud, aun cuando en las condiciones más severas también debieran atenderse a nivel secundario o hospitalario. Este diagrama es el propuesto de rehabilitación en COVID, donde hay una puerta de entrada que es el long COVID, que es la persona que consulta posteriormente o que no estuvo nunca hospitalizada e ingresada. Y tal como está puesto aquí, los servicios prioritariamente debieran hacerse en la atención primaria de salud. Actualmente se está en estudios de verificación de costos individuales y de demanda para realizar a nivel país un GES, que son las garantías explícitas de salud, donde ahí tenemos distintas condiciones de salud que están garantizadas respecto a COVID y que incluiría también el post-COVID. Este diagrama puede encontrarse en el protocolo de rehabilitación en personas de COVID grave y crítico, que también fue elaborado por este departamento. Respecto a las modalidades de atención, como ya dije, hemos dicho que puede ser desde un seguimiento telefónico, también un seguimiento presencial, incorporar la estrategia de rehabilitación a distancia, que también prontamente será publicada una orientación técnica respecto a esta estrategia, y la atención domiciliaria en los más severos. Respecto a las recomendaciones de intervención, tenemos las distintas áreas de la rehabilitación, con énfasis en la prescripción de ejercicio, mejorar la tolerancia al esfuerzo, detectar las alteraciones cognitivas por un lado, y por otro lado hacer estimulación principalmente de funciones ejecutivas, el abordaje de salud mental, sobre todo derivando a los equipos de salud mental cuando es necesario, entrenar las actividades de la vida diaria, tanto básicas como incluso planear y orientar respecto al retorno laboral en quienes no han podido realizarlo. La rehabilitación fonoaudiológica con foco en el manejo del habla, el lenguaje y también las alteraciones de deglución que puedan estar quedando como secuelas, ya sean leves o más severas. Y siempre acordar una evaluación y un manejo nutricional, valorando la adición incluso de suplementos vitamínicos. Algunas consideraciones sobre la fatiga contenidas también en nuestro documento de recomendaciones, de lo cual yo principalmente rescato que hay que siempre monitorizar a las personas con una escala de Borg, puede ser, También incluimos un inventario breve de fatiga adaptado y el descanso intermitente que ya fue mencionado previamente, que es importante que la persona vaya a su ritmo. Y finalmente comentarles que el equipo de evaluación, el Departamento de Evaluación de Tecnologías Sanitarias y Salud basada en la evidencia del Ministerio de Salud realiza distintas recomendaciones clínicas basadas en evidencia, y dentro de las intervenciones de rehabilitación también hemos incluido preguntas y respuestas respecto al long COVID y post-COVID para apoyar nuestras acciones. Eso les puedo compartir. Muchas gracias.
Muchas gracias, doctora Rojas, y sin más voy a dar paso a nuestra próxima panelista. Nuestra próxima panelista es Megan Carmilani. Espero, Megan, que haya pronunciado tu nombre bien. Megan nos trae una perspectiva diferente, nos trae la perspectiva desde el punto de vista de los pacientes y los familiares. Entonces, Megan, muy interesante, formó una organización sin fines de lucro que se llama Familias para Long COVID, o la traducción en español, y Megan lo hizo porque había ella misma sido paciente de síndromes postvirales con 2 historias en su niñez de mononucleosis, y cuando empezó la pandemia, familiares, amigos se acercaron a ella compartiendo experiencias, y ahí ella decidió que iba a hacer, a moverse a constituir esta fundación. Así que es una perspectiva muy importante en relación a la organización y gestión de los servicios, y por eso me llevé un poquito más de tiempo para presentar a Megan. Adelante, Megan, con tu presentación. Gracias por estar con nosotros.
Thank you. Now, can I just verify everybody can see my slide? Okay.
Yes.
Yes. Okay. Thank you. Thank you for the introduction. My name is Megan Carmilani. I'm with Long COVID Families. We're based in Charlotte, North Carolina in the United States. As was explained in the intro, I got diagnosed with mono twice when I was a child, and I developed post-viral syndromes. And it's 30 years later, and I still have them. And I will share that my symptoms as a child are the same that I'm experiencing as an adult. Nothing changed, I just got older. So what happened was, when the pandemic started happening and I had friends who were starting to experience similar symptoms, they started contacting me. And then we started noticing similar symptoms in children. And that is how I ended up getting involved in deciding to start Long COVID Families. So Long COVID Families is here I am. That's my daughter, Anna. Long COVID Families is a nonprofit that supports children and caregivers whose lives has been disrupted by triggered illness. Our community is primarily people who had mild COVID, if not asymptomatic COVID, and later developed long COVID symptoms. This is mostly a non-hospitalized population that's in our support groups. In our community, we recognize that illness is a disruptor. It disrupts every aspect of someone's life. So we foster reconnection. We have 3 pillars at Long COVID Family: connection to self, connection to family, and connection to community. Regarding connection to self, illness disrupts our connection to our bodies. Long COVID often comes with chronic pain and strange new sensations. The natural response is to disconnect from our bodies and to dissociate, which is our way of protecting ourselves from the pain. But that also makes it difficult to work with healthcare professionals because it makes it harder to explain symptoms. It makes it harder to tell if an intervention is working. We recognize that this is a trauma response, and our community has found relief through somatic-based trauma therapy. We also believe that talk therapy does not help with this specific situation. Our second pillar is connection to family. Long COVID can disrupt a family. Maybe the provider can no longer work. Maybe the caregiver can no longer cook. There's actually a high divorce rate in families with post-viral syndromes. We help by offering a safe place to have conversations around the unique experience of caregiving while sick, or caring for a loved one who is sick. Our third pillar is connection to community, because with chronic illness comes isolation. And we help people stay connected to the world by offering support on how to get accommodations at work or at school, and guidance on how to apply for long-term disabilities within the US. Lastly, advocacy. We share our knowledge and experience to affect change, and I appreciate the opportunity to be here today. Let me share our patient experience with you. Oops, excuse me, I skipped a slide. So Jenna. So here we have Jenna, and Jenna is 8 years old. She's a competitive dancer and she's hypermobile. One of the things we've been noticing in our support groups is that many of our children are hypermobile. Jenna's father tested positive for COVID at work, and the rest of the household was sick, but was unable to get tested. This is common with children because they were either asymptomatic or very mild, and the families did not think to test them or did not have access to a test. Everyone in the house experienced mild illness. After a few weeks, they were able to resume life. However, approximately 29 days after the initial infection, Jenna started to tell her mother she didn't feel well. Her mother kept checking her temperature, which was normal, and figured she was just trying to get out of school. Well, no, actually, Jenna had developed long COVID, and this is her journey to date. After a few weeks of symptoms, Jenna saw a pediatrician who ran routine blood work and iron levels. The test came back normal. The pediatrician said everything was fine and she just needed more time to heal from COVID. Jenna became more and more fatigued. She stopped going to her dance lessons because she doesn't have the energy and her legs ache. 2 months after, Jenna went back to the pediatrician. However, her symptoms were so vague and seemed to come and go, the doctor was not sure what to do. So he referred her to neurology, a child psychologist, and a physical therapist. It was months before Jenna saw a specialist. In the meantime, she went to physical therapy. Jenna was able to perform the exercises during therapy, but later she felt sick. She was dizzy when standing. The leg pain she was experiencing had decreased some, but it was still present, and she's exhausted most of the time. After 6 months, the neurologist performs an in-office exam and suggests that Jenna needs to increase salt, water, and wear compression socks, but she's not given a diagnosis or any further testing. At month 8, Jenna is no longer able to attend school full-time, and she spends most of her time at home. She now complains about forgetting things and not understanding the teachers. Her grades have suffered immensely, and she has been diagnosed with anxiety and depression. At month 10, she's able to get into a COVID clinic. There is an extremely long waiting list. Once she's there, they perform more tests. The tests come back normal, and they tell her this is new and we're still learning. Meanwhile, we have research that's recognizing these following conditions in adults, and these are some of the diagnoses adults in our groups are getting. With the same symptoms as Jenna, the condition of post-exertional malaise is being recognized. MECFS is getting diagnosed. Mast cell activation syndrome, or MCAS, is a common diagnosis. Orthostatic intolerance is common. So I'm going to use my time today to highlight a few things about post-exertional malaise and MCAS specific to rehabilitation for patients. Patients with PEM often are unlikely to recover unless the underlying mechanism is addressed, whether it's autoimmune condition or something else. And we don't know what's causing PEM in long haulers at this point. It's important to recognize that not everyone will get better. And we, as a patient community, would like more focus on quality of life and less on abstract improvement. We are also going to ask that we are not shamed as patients when we don't improve, because many people do feel shamed as though they're not trying hard enough. Things like graduated exercise therapy is a disproven method for PEM, but still it is primarily what is being prescribed right now, at least in the United States, without evaluating whether or not PEM is being experienced by the patient. Sorry, guys, I'm a little trigger happy with my slides. So let me go to the concerns here. Here are our community concerns. Our doctors recommending cardio. It seems to be the primary recommendation of any long hauler when they first start seeing a doctor. It's rare that doctors are discussing the possibility of PEM, and they do not discuss the test of the CPET at all. Doctors are recommending to push through. And this is incredibly dangerous for our population without knowing, without running tests. Specifically going back to patients with MCAS, I do want to highlight that exercise and exertion is a trigger and will further activate mast cells, causing a histamine release, which may trigger dysautonomia symptoms in some patients. And that's something to be aware of. Some patients say that they or report that they feel relief from mast cell stabilizers and antihistamines. And once they are put on these medications, they are actually able to resume exercise. But we are still concerned about doctor recommendations to push through. What we also have is a lot of referrals to psychologists and psychiatric professionals, especially if the patient is from a marginalized community or a child. Our community does not find that helpful when it's offered in place of medical care, and that happens a lot. We are specifically concerned with the pediatric diagnosis of amplified musculoskeletal pain disorder, or AMPS. This is a controversial diagnosis, and it's sometimes described as juvenile fibromyalgia. The treatment is graded exercise therapy, cognitive behavioral therapy, and children are told to ignore their symptoms. The research surrounding this is controversial, and many academics question its validity. There is no evidence linking AMPS to COVID, yet it is one of the primary diagnoses in the US for the pediatric population right now. There is a controversial inpatient program in several pediatric hospitals throughout the US. Patients whose symptoms worsen are simply asked to leave the program, and they are not counted in the success rates. When we talk to adults who attended these clinics as children, they describe it as abuse. I want that to sit for a moment. They describe it as abuse. This is the #1 diagnosis for a pediatric population suffering from long COVID. And most of these kids are being referred to the clinics that patients refer to as abusive. So symptom management, what does work? From our population, many of whom are experiencing post-exertional malaise, activity and symptom tracking is very helpful. It helps us learn our bodies. So I have post-viral syndromes from when I was a kid. It's been 30 years. I don't have long COVID, but I do have post-exertion malaise. It's 30 years later, I still have it. The activity and symptom tracking was one of the most beneficial things I've ever done. And many of our community would agree, to learn my body and learn how to re-engage with life. Body awareness is very important. Understanding energy envelope, spoon therapy, heart rate monitoring was a useful tool for many of us to learn what is actually going on in our body, because we have these really strange sensations we've never experienced before. Like for many of us, it's the first time that we're experiencing tachycardia. And tachycardia, when you experience it, it feels like you're under attack, right? Like there's something going wrong in your body and alarm bells are being set off in your body. And something is really, really wrong. So then you get like the amplified sense of panic that kind of comes with that. If you understand what's happening with your body, and a heart rate monitor can help do that, it's easier for you to recognize that, okay, my heart is spiking because maybe I have POTS and I stood up. It's okay, it's going to pass. And that really helps improve quality of life. The more we know and understand about what is happening in our body. So we know PEM is not caused by deconditioning, but we do recognize as patients that it can cause deconditioning. The type of exercises we like are strengthening exercises, floor exercises, breathing exercises. We don't like cardio. I work out 4 to 5 times a week now. I'm also on medication and have received excellent treatment. I still struggle with cardio. We also want to learn about how to survive a crash and a flare. And one of the things with the crash and the flare, again, is that that's important to understand is that in the patient community, we sometimes call it an impending sense of doom, because your whole body kind of goes on alert that something is wrong. And it's really helpful to know that this is a normal part of post-viral syndromes. And that what I do personally is I simply acknowledge it's happening. And I say to myself that, it will pass, right? That my body's saying it's going into a crash. I need to take care of it. I go lie down, I put a weighted blanket on, and I wait it out. The weighted blanket helps with the nervous system quite a bit. And then the darkness of the room and everything helps. And then just calmly telling myself it's okay, I am safe. That seems to be very helpful to me. And knowing that it's going to pass is helpful to work through those crashes and kind of minimize them. Many of our patients experience, or many of our people in our communities experience dysautonomia. There's lifestyle changes, medical support for that, but I want to emphasize the pushing through. We've had doctors tell our community to push through the fatigue, push through the sense of dizziness, and just want to highlight that there's actually, especially in a patient population before they have access to a tilt table test, which there are very few in the United States. And most people, we're on waiting lists for like 1.5 years, 2 years to get a tilt table in some places. So telling people to push through, you're risking a potential fall risk, because I have dysautonomia myself, I have POTS. The lack of flow and oxygen to the brain, doctors need to be aware of that and what they're actually telling patients. Many of us in the community experience pain, inflammation, and allergy, whether it's mast cell activation, fibromyalgia, small fiber neuropathy. Hypermobility is very, very common. We think the virus may be exacerbating that in some way. So what's very helpful for patients is really, again, tracking your symptoms, tracking what triggers you, learning about your body is probably the most helpful thing. Understanding if you are hypermobile, understanding what that means, and how to care for your body, because the way you exercise is actually slightly different because of the way our joints move. And I will bring up, for many of us, we have a lot of pain that's rooted in trigger point knots. And what we find very beneficial is dry needling and acupuncture. And when you combine dry needling with like physical therapy, it seems to be very, very helpful for a large segment of our population. And it seems to do something to the nervous system, which I don't fully understand, but I can tell that my nervous system feels calmer. Okay. And thank you. I appreciate the time and the opportunity to speak with you.
Muchísimas gracias, Megan, por compartir con nosotros la perspectiva de las personas que tienen condiciones como es la condición post-COVID. La verdad que tenemos al momento 2 perspectivas importantes. La anterior, con la perspectiva de cómo se organizan los servicios con las autoridades de salud a la vanguardia. Esta perspectiva que es fundamental para poder hablar de un enfoque de un modelo de atención centrado en las personas, en las necesidades específicas y diferenciadas de las personas. Y entonces vamos a pasar a una tercera presentación con la doctora Marta Imamura. Marta nos va a hablar de una intervención específica de modalidad de servicio que es la telerehabilitación para atender a los pacientes con post-COVID-19. Marta, adelante.
Muchísimas gracias, profesora Amalia. Es un honor muy grande estar aquí en este panel, en este webinar tan importante. My name is Marta Imamura. I am Associate Professor at the University of Sao Paulo, Faculty of Medicine, and our Institute of Physical and Rehabilitation Medicine is a collaborating center for PAHO and WHO for rehabilitation. So it's an honor to try to address to you one of the models of care that we have been really used throughout the world in terms of managing these people with long COVID or post-COVID-19. It is really important to realize that definition because, as what we very strongly emphasized by Dr. Carmilani, the recognition of this condition is very important. And even though it may seem sometimes symptomatic and vague, it's important to realize and try to link that occurrence of those symptoms with the post-COVID-19 symptom. As highlighted already, there are several sources in these people that could cause disability and impair their functioning status. So what is the role of tele-rehabilitation in the model of care delivery? So we use the WHO definition of telehealth, and it's very important because in rehabilitation, it's not only medicine, but it applies to all health professionals that are involved, super important, in the rehabilitation process. And it is basically the delivery of healthcare services at a distance using communication and technology to exchange information in terms of diagnosis, treatment, prevention, monitoring, even for research, and also for continuing education of healthcare providers, and at the end of the day is to advance people care in their communities. There are some important technical issues that to provide this overall benefit to patients, because it increases the access to general and specialized healthcare providers. It is delivered in the remote areas. For example, some challenge that in the Americas, at least in the Latin America countries, we had in accessing rehabilitation from rural areas. COVID-19 pandemic, dealing with this new technology, allow us to reach out to these people. Also offering flexibility in terms of scheduling and cost effectiveness in terms of, for example, time consuming, and also the transportation from people, especially from those living in more distant area, and again, yet providing excellence of care. So when we first addressed this COVID-19 pandemic, there was this important pulse survey from WHO, and showing that almost 90% of medical care and service delivery had the disruption in most of the countries assessed in that pulse survey, and rehabilitation provision was one of the key health strategies that were more, let's say, impaired the provision during COVID-19 pandemic, especially in the beginning. Our collaborating center for PAHO was fortunate enough to have already in place that technology that needed to be, have some adaptations, but we already had in place the technology available to keep contact with the patients, because at the very beginning of pandemic, we were not able to assess people because they were not able to come to the rehabilitation settings. And so using either the telephone or internet communication synchronous, we were able to at least contact people, see how they were doing, and even monitoring and identifying possible COVID-19 symptoms. And the importance of this talk now is to realize how tele-rehabilitation can be implemented in the entire spectrum of care, from the informal and self-directed care, going through all the pyramid up, going through the community delivered rehabilitation, the rehabilitation integrated into the health systems, the secondary care, and also even in the tertiary or very specialized care for complex people. COVID-19, for example, that required hospitalization or inpatient rehabilitation to deal with all the several body parts or body structures and the functioning and lack of participation they presented throughout the course of their onset. So our hospital had the opportunity to collaborate with all the departments within our university medical school, including psychiatry, cardiology, pneumology, internal medicine, and pulmonary medicine, and assess all these people who were hospitalized in our hospital, which is a reference center in Latin America. And the first wave was COVID-19 management people, restricted to those people. So assessing those who survived and who were discharged from hospital from 3 to 11 months after hospital discharge, so these were about 800 people, we could identify that, fortunately, from those discharged from hospital, about 70% had no or very minimal impact of functioning due to COVID-19. Whereas about 30% required or had some limitations in participation and activities that would require then a more specialized wear. This is so important, number one, to realize that in the course time of after the hospital discharge, it seems that the functioning impact is somehow maintaining similarly throughout the months. And so all the symptoms that were already addressed. So how we used rehabilitation, how the literature treats with this. So we have mainly 3 modalities. One is the real-time, both teleconsultation or tele-rehabilitation. It is we call synchronous mode. We provide consultations, follow-up, examinations. It could be used either with a telephone, with platforms. For in our case, it was completely embedded in our electronic files. And also we can use text messaging. All of those have advantages and disadvantages. So when we do those audio, video, or audio only, there are the synchronous 2 ways. So you have the patient, the care provider, and then we can access the patient needs, rehabilitation needs. There is the ability to assess the home environment of our patients and also test the access that we are doing. There are some benefits of those interventions. For example, physical distancing, reach out remote areas, keep the continuity of care when, for example, the lockdown or the social distancing or restrictions are in place, and also for the patient, it's a more patient-centered, almost unique to one, and also increasing the efficiency. Several reports already say that COVID-19 pandemic was an accelerator to empower telerehabilitation as a mandate for all the health professionals involved, the rehabilitation team. Important to realize is that, so for example, we had a publication from our collaborating center only. So there were more than 22,000 consultations in the short period of time. When we compared even to face-to-face, of course, over time it changed. In the beginning, it was more remoting or tele-visiting, but then we could bring people again back to the hospital. And for example, for today, we have over almost 200,000 consultations, managing, monitoring already in place using the technology. So also it's very important the users. For example, for some people, it's better the telephone. For some people, they have the ability, the technology, the electronic literacy to be able to use all those forms. Even we identified that capturing some of the physical examinations were possible remotely using some simpler methodology, even follow up with the patient live at their home and to guide them into their exercise program or other rehabilitation facilities. And also a very important component of telerehabilitation is about the ability to monitor, for example, after discharge or after a set of treatments, how they are doing in terms of vital signs, in terms of physical capacity, mental health. There is also this to use asynchronous, which means you record the imaging, you record the text, and then you can use it later on to share the information with other team members, with other even institutions. And even though some of the technologies, for example, for those COVID-19 patients that are not possible using telemedicine, at least we can monitor people and can teach them how to use some of those at home if the safety issue is present. To end this presentation, technology is evolving, so you can have monitoring more and more of the physical ability of our patients, and also with applications. So for apps, our hospital has developed even for mental health and for physical rehabilitation videos and instructions that people can use over time. Remember that these people have mental consequences, cognitive consequences, very well highlighted in the previous panel. So it is really important to take that into account, maybe a barrier to telerehabilitation. There are some limitations, for example, the need for privacy, the licensing of the health professional, patients' access. Sometimes people still don't have access to a good internet band yet. The meaning or the taking message is that telerehabilitation, COVID-19, for example, was an accelerator to the implementation for all team members, social workers, psychologists, etc. There are limitations, but technology is evolving, and hopefully in Latin America and the Americas, we can use this technology that even though the pandemic is over, there is a place for this technology. Thank you so much for your very kind attention.
Muchísimas gracias, doctora Imamura. Yo veo que Megan levantó la mano para hacer una intervención. Megan, adelante, y luego voy a pedir permiso a ver si podemos hacer algunas preguntas. Megan.
Hi, I'm sorry, I don't have the translation going. Could you?
Okay, sorry, no problem. So I saw you raise your hand.
Oh,
okay. It was a mistake. So for the purpose of closing with this session, Anthony, I don't know if we have few minutes. I don't see many questions actually. What I see in the chat is a lot of comments of congratulations to the three panelists. They have been excellent. Merely one question related that I can place to the floor. But Anthony, you let me know if we can close the panel and continue.
Yeah, I think you're right. There's a couple of questions, and I think we can have a couple of minutes just because I think the panel has been so great. I think there's an excellent question that's talking about considering the main clinical factors relating to persistence of symptoms, what interventions in health, community, and social services could be prioritized. And I think that could be a very interesting, quick thought from each of the panelists, perhaps.
Well, if we have time, then I want to place one that I think is very relevant for everybody. Sure. That is a question para Marianela, porque la doctora Ríos se refiere al financiamiento de estos servicios, porque sabemos que, y eso se relaciona con alguna pregunta que vi de las presentaciones anteriores, si no tenemos financiamiento y recursos, entonces es difícil avanzar con la implementación y la expansión de los servicios. Y la pregunta para ti, Marianela, si te puedo tutear, es si es que hay financiamiento disponible en Chile para continuar estos servicios. Y luego voy a pasar a otras para compartir con el resto de las panelistas. Adelante, Marianela.
Gracias, muchas gracias. Sí, es un tema importante. Hasta ahora lo que se ha hecho fue lo que mencioné al principio, un poco más bien la reconversión de los servicios que ya existían, pero en la actualidad se está trabajando, ya se presentó la propuesta de incluir la enfermedad por COVID-19 en las garantías de salud, las garantías explícitas de salud aquí en Chile, que son un grupo de condiciones de salud. Actualmente hay más de 80 condiciones de salud incluidas, particularmente en estas garantías que, tal como su nombre indica, explicitan algunas prestaciones importantes a considerar en las condiciones de salud que incluye, y en este caso incluiría todo lo que tiene que ver con rehabilitación desde el más agudo hasta el seguimiento del post-COVID. Eso está actualmente en estudios de evaluación de costos justamente.
Excelente, Marianela. Eso le va a dar sostenibilidad realmente. Hacia ahí quisiéramos avanzar. Voy a hacer, I'm going to place a question that maybe for Mega and for Marta, and you can give your perspective. And it's in relation to all of these comments that are in the chat, highlighting the need to have a comprehensive, holistic approach when we look at the aspects related for rehabilitation. Can you give us your thoughts about, from the different perspective, from Megan, your perspective as a patient and living with conditions, and Marta, your perspective as from the academic, from an academic institution. Megan?
Sure. I think it's very important for everybody to realize that when you get an acquired disability, really, that it is a threat to your survival. And that is where the patient's perspective is coming from, because it impacts people's ability to work, provide food and shelter, care for their children. And so just how scary it is. And then to go to doctors who don't seem to understand, it compounds how scary it is. And so I think that understanding the big picture, that this is more than just medical, this is our entire lives that have just been flipped upside down. And there are some people who are now like losing homes and unable to provide. And we need to be looking at this collectively, and the ripple effect, I think, is underestimated. So when a caregiver, we're noticing it's primarily mothers, right, of a certain age, so they usually have children in the house. If the caregiver is sick and unable to care for the children, the ripple effect in the entire family and then the entire community is huge. Is what I really would like people to emphasize and understand.
Thank you, Megan. Marta?
Yes, Dr. Marianela. So we actively call people who were discharged from our hospital and made a questionnaire. So I am not sure if all those 800 people would come spontaneously to seek healthcare. So I would recommend starting with the general scale. So for example, we use the post-COVID-19 functional status scale. So it says, oh, I have no limitations in my everyday life, no symptoms, pain, depression, anxiety related to the infection, or I have negligible limitations. I suffer from several limitations. So still start broad, and then WHO provided the guidance. So it's fatigue, it's shortness of breath, it's cognition. So as a collaborating center, we translated the booklet that WHO Euro produced, very didactic, very to the point, in all sorts. So you have a podcast, you have the PowerPoint, you have the text. We translated it to Portuguese and placed it into our website. And the number of downloads is amazing. So you can reach out people just by giving guidance and open a line. So after seeing these people, we really believe that the majority of people will benefit from the community-delivered rehabilitation. So those are the health professionals that should be aware of that definition from WHO, who is brilliant, and try to make it the link that this is not just a symptom elsewhere, but it's related to COVID-19 and must be addressed. And then bringing to the tele-rehabilitation, even a phone call. For example, in Brazil, by law, you can even use WhatsApp to contact patients. So it is to facilitate access to rehabilitation. If you remember the Lancet publication 2021 by Professor Aguilar, before COVID-19 pandemic, 1 out of 3 people in the world would benefit from rehabilitation before COVID-19. So now with long COVID, with the physical, the conditioning, mental and also physical, it's the time to grab the opportunity and emphasize rehabilitation as a key strategy for health in the 21st century, because Surgical interventions, drugs, medications will not manage the symptoms that long COVID-19 people present. Thank you.
Mega, you have your hand raised,
Yes.
and now it's real.
It's real this time. I do want to take the opportunity to talk about for a moment how difficult it is to recognize long COVID in children, because children do not know what normal is. They don't know what normal bodily functions are. They don't have the language to articulate what's going on internally. So not only do they have to figure out how to say it to their caregiver then has to understand and then explain it to a doctor, and then the doctor has to understand, and there are so many layers to it. And I do think we have a massive underdiagnosis of children who are struggling. I would suggest that we are seeing a pattern in families. If there is a caregiver who has long COVID and the entire family had COVID, I would take that and probably screen all of the children, because it's likely at least one child has COVID. It seems to be happening in families. I don't know if that suggests something genetic vulnerability going on, but it's a clue to start looking at children. And we are finding if you intervene early, you get better results, right?
Excelente. Creo que con eso ya sí vamos. Marta, ¿tienes tu mano levantada?
Yes,
minutos, porque ya tenemos que cerrar.
Yes, I could not, I so much thank Megan for this comment, because children with COVID-19, they can have problems in learning, their immune system so stressed, they can age earlier. So it is really a matter of concern, and we should, or maybe you should organize a webinar on that topic.
We will have to coordinate a webinar on that topic. And with that, I would like to close this panel. Thank you very much. 2 or 3 key messages. Number one, if we talk about access to quality comprehensive health services, in which rehabilitation is an important part, we need to start understanding the specific needs of people. And thank you, Megan, for bringing that perspective. 2, it is important that to recognize that to move even to innovations like tele-rehabilitation, there is a lot of things that are behind that is more than having access to technology. Health systems, key health systems areas that, thank you, Marta, for bringing the perspective of one intervention that can facilitate and expand services. And then thank you, Marianela, for reminding us that behind that we need systems, we need financing, we need standards, and we need really processes that are from the perspective of organizing and managing services. So it's been excellent, the complementarity. Thank you very much. And with that, Anthony, I turn to you.
Thank you, Amalia, and thanks to everybody. Really, really exciting panels, and I let them run. We're at the end of the session, and if you'll indulge us for just a few more minutes, just so that I can talk about what's happening in the next steps, because I think with these webinars, it's wonderful to hear and to get perspectives and hear from people. But what I really want to hear is what's coming next and what we're doing about it. And I know a couple of questions have come up about how APAHO is supporting, and to share with you a couple of the next steps so that you can keep informed about what's coming next. I have got a link at the end. I know a lot of people have asked about the recordings of this webinar. They will be on the event page of the PAHO website that you registered on. And I have the link at the end. And I know Jimena has been sharing that link as well. So I think as well, we're able to share around with you with the registration as well, the link to the recordings, but it usually takes a day or two just whilst we upload them and clean them up, and then they will be both in English and Spanish on the website. But I just want to have an extra 5 minutes just to talk about a couple of activities that we're doing that are coming up in the coming months that we're excited to be launching and developing, and we're keen for the community's input on as well. myself and my colleague Wouter from WHO, who's leading on the rehabilitation clinical management side, are going to just share a few updates with you about work that's happening in the region and then more globally as well. And the first to say, many of you, and I know it was in one of the slides earlier on from Dr. Sahagún, the rehabilitation considerations document that we published in April 2020, really talk more about the acute side of access to rehabilitation for those who are hospitalized. We're in the process of updating that with the evidence that's emerging on long COVID and post-COVID condition, updating new references, and hopefully in the next couple of months, we'll be publishing the second edition of that document. The document is structured really around different elements of society. So advice for governments, advice for rehabilitation service providers, other clinical providers. So it's really targeting different stakeholder groups and what you could be considering to ensure people have access to rehabilitation. And again, we will do an announcement once that is updated. It will be published in English, Spanish, French, and Portuguese. We're also just starting a rehabilitation and COVID-19 working group with some of the panelists you've seen today and some others as well. Really keen to make sure that that group is represented from members of the rehabilitation clinical, academic, and leadership communities. And I know a couple of people have mentioned academia and what role research and researchers has to play. And the answer to that is absolutely enormous roles. We know certain things about COVID and post-COVID condition, but there is enormous amounts that research is really, really needed to help broaden our understanding, to help broaden what interventions are effective. And so the research community has an enormous role today and to play. And I know that the 3 R's of recognition, rehabilitation, and research is a crucial area of that. So there's an enormous role for the academic community to play. And also making sure, and we've heard from Megan, her firsthand experience, and that I think we'll all agree, the contributions that Megan has given today have been crucial in helping us as clinicians, as policymakers and providers, to think about how we're shaping this response. And we can't make a comprehensive response without the long COVID community joining forces with us and working together hand in hand with us to help understand the impact that this is having at the population level, at the people level, and how we can make sure that we have a person-centered response and approach. The next is in December, there was the WHO launched a scientific brief about rehabilitation in COVID-19. If you've not seen that, it is on the WHO website for rehabilitation. And that's being translated into Spanish and Portuguese right now and should be available in the coming weeks for those in Latin America. And I think Marta mentioned the WHO Euro leaflet support for rehabilitation self-management, which has already come into Portuguese and should be available in Spanish as from the 1st of March as well. A really good document for practical guidance of different aspects of rehabilitation and self-rehabilitation, and contains a really good guidance in terms of post-exercise malaise and pacing and other sides as well. So we've, again, the Euro team worked very closely with the long COVID community in crafting those sections, and is a really, really powerful and useful document. And before I hand over to my colleague Wouter, just to sort of say that there has been, since the middle towards the end of last year, a course for rehabilitation on COVID-19, which is on the Open WHO website. And I can put the link in the chat while Wouter is presenting. And we've been translating that into Spanish as well, and should be added to the PAHO virtual campus next month. And following on from that, we're really excited to be developing a 2-day virtual follow-up workshop for professionals who go through the virtual course, and then doing some follow-up in terms of putting those learnings into practice as well. And we hope to launch that virtual workshop in June, and if it's popular, probably repeat it towards the second half of this year as well. So a lot of activities that are ongoing. I'm going to hand over to Wouter now to talk a little bit about a third piece of work that the WHO are developing about the interim guidelines of rehabilitation. Over to you, Wouter.
Thank you, and I will do it without slides, I guess, for the interest of time. So adding to what Anthony just said, do you hear me all right?
Yes.
Yeah, okay. So we are currently developing at WHO headquarters, developing a interim guideline for the rehabilitation of post-COVID-19 condition. So this is this has been requested by patients, clinicians, and member states. And so this will be like an interim or rapid advice guideline, because our evidence base has been very limited up to this point, looking at probably a short shelf life while evidence is emerging. But still, the rehabilitation community and patients do need some guidance in terms of the rehabilitation of the post-COVID-19 condition. So in collaboration with the clinical management team at WHO headquarters, we have decided to incorporate this guideline into the overall clinical management of COVID-19 living guidance document. So this is a guidance document that is published whenever there's an update. So looking at the next publication, probably in a few months. This interim guideline for the rehabilitation of post-COVID-19 condition will make clear and actionable recommendations, and will be targeting both program planners and clinicians. So looking at ministries of health, managers of rehabilitation programs, and rehabilitation workforce. It is a work that involves a steering committee and then the Cochrane Rehabilitation, which is supporting us to provide the evidence base for the development of the recommendation, both for indirect evidence and direct evidence. So, and this is done with a large group of experts from across the globe, from the different rehabilitation profession types. The scope of this guidance document will be twofolded. We will develop recommendations for the clinical rehabilitation management of fatigue, breathlessness, post-exertional symptom exacerbation, orthostatic intolerance, cognitive impairment, anxiety and depression, dysphagia, and even return to work. And then as well, recommendations that look at the model of care for the post-COVID-19 condition rehabilitation. So looking at what are the core components and the functions of a model of care, what is the workforce that is recommended to develop services, red flags for safe rehabilitation, and the service delivery setting. So this is currently being developed at the stage of final review, and hopefully looking at the publication within a few months, and then launching with a webinar. And I'm sure you will be invited through the PAHO office. So thank you, Anthony, for this opportunity to share this activity.
No, thanks, Wouter. A huge amount of work being done there, and we're really excited for that document to come out. Lastly, just to say, and again, I think there was a question before about how we connect with the work that's been doing about building rehabilitation as an integral part of the health system and part of Rehabilitation 2030. And I think just to say that that is being done. We're really starting to implement some of the Rehabilitation 2030 tools. For those who don't know Rehabilitation 2030, it's a call for action to ensure rehabilitation is an integral part of health system interventions. As Marta pointed out, 1 in 3 people, even before the COVID pandemic, had been identified as having a potential need for rehabilitation. It's a huge number and not sufficient rehabilitation workforce to address those number of people. So we're really integrating then the COVID-19 components into national evaluations of rehabilitation systems, into reviewing policy and developing new policy and programs, and supporting member states in order to do that. So at country level, we're really working on that and integrating COVID into the existing tools that we have for rehabilitation sector strengthening. So I'm just going to post a slide that has the links to the webinars, to the recordings, and then I'm going to hand over, whilst this is showing, to Dr. Renato Oliveira for some closing remarks. Thank you, Renato.
Thank you so much, Anthony. It's a great pleasure to close today this excellent discussion, which has focused around the rehabilitation perspectives for post-COVID-19 condition, or long COVID, it's often referred. I have learned a lot today, I have to admit. So we heard in the first panel an overview of the latest evidence for rehabilitation, and in particular perspectives on interventions relating to two of the most commonly reported symptoms, fatigue and cognitive difficulties. You might recall that during the second panel, we have heard about experiences relating to facilitating access to rehabilitation, including the development of plans and policies in Chile, users' experiences, and an example of telerehabilitation as a mode to enable more people to access rehabilitation professionals. Finally, we heard from our colleagues leading on rehabilitation at WHO and PAHO regarding work that we are doing and we will be launching in the coming months to really support countries and individuals on post-COVID rehabilitation. I'd like to thank all the panelists and presenters today for their excellent interventions. Clearly, as a region which has been so heavily affected by COVID, it's crucial that we in the Americas are appropriately recognizing, researching, and responding to the population's needs with regards to post-COVID condition. As mentioned at the start of today's webinar, this is the start of a multi-series of webinars which PAHO will be hosting related to post-COVID-19 condition. In the coming month, we plan to have additional events relating to mental health and neurology and health systems and service integration. So please keep your eye out for announcements about these specific web events. We very much welcome feedback and suggestions on how PAHO can provide further support to ensure actions on post-COVID condition across the region. So please reach us. And finally, I'd like to thank the interpreters, practitioners, and all the support team involved in the organization of today's event, and especially to you for attending and participating today. So thank you so much. Warm wishes for the rest of your day.
Gracias. Thank you, everyone. Great webinar. Thank you to all of the wonderful panelists and the moderators.
Thank you. This